pleasure being in this arena, and it is really interesting to see the newer developments. We have a very interesting speakers and who have well established, started their careers in open surgery, then went on to laparoscopy, and then went on to robotics, and then have switched over to HIFU, and then they will be able to share all their experiences about the system. We will begin the program with our first talk on uterine fibroids and adenomyosis and its impact in assisted reproduction. Patrick Steptoe and Robert Edwards performed the scientific feat on 25th July 1978. We have come over about 44 years now. A lot of improvements have taken place since then. We have developed ICSI, IMSI, PICSI, assisted hatching, PGS, PGD, you name, right up to the artificial intelligence, we have developed them. But the success rate has not increased significantly. What was there at 20, probably around 30. We have some troubled areas like endometriosis, fibroids, adenomyosis, for which we do not have a very clear answer yet. In the picture here, you will see Robert Edward along with the mother of Louis Brown, and Louis Brown carrying her own. That the second generation has just come back. Now let's look at the results of an IVF program. It depends upon the age of the patient, ovarian reserve, male factor, stage of the transferring embryo, uterine environment, luteal support, and absence of additional risk factor. All of them contribute to the results of an IVF. What we say is about a limited, say 30 or 35, we try to push the patient into that particular arena by eliminating all these things. Now let us focus on the uterine factor. This is on the size and shape of the uterine cavity, endometrial lining, endometrial blood flow, myometrial support, fibroids, and adenomyosis. All of them put together is contributing to this particular. Now, if you start with fibroids, we know that the incidence of fibroid is about 25 to 30%. So if so, there is some increased incidence in ART about which we will see. So what are all the options available? We have some medical methods of managing a fibroid, and then we have surgical methods like open myomectomy, laparoscopic, robotic, and there are a lot of newer advances has come about which we have eminent experts who will be waiting to talk to us about it. But overall, what we plan is a stimulation, ovum pickup, and freezing of the embryos, followed by management of the fibroids prior to the embryo transfer. Because surgery, to a certain extent, can impinge on the ovarian reserve. And that is the reason we try to do the pickup and then plan for the surgical treatment of the fibroids prior to the surgery. But here, what are all the problems in the management? One is the cost of the treatment of the fibroids and adenomyosis. The most importantly, the aftermath of the treatment, that is the scarring of the cavity and decreased vascularity in the cavity. Time taken to heal to be ready for an embryo transfer, and patient's emotional stress, and then again worried about the results of the embryo transfer and treatment of the fibroids and adenomyosis. How does this infertility and myoma thing interrelate? So this is controversial, mainly because it is difficult to prove the causal relationship. There are about 70 to 80 studies indicate the pregnancy rate is about 50% after the myomectomy in infertile patients. But there are no well-controlled or randomized studies, no clear description of the size and number and location of the fibroid, and no standardization of the diagnostic methods with different outcome parameters. The results, as per the Jacques-Donnay studies, varies right from 10% up to 70%. So it is more commonly seen in IVF patients. Why? Mainly because there is a delay in childbearing when the fibroids are more common. So when they become a little bit older, the fibroids become more common. And, as the age advances, the fertility decreases. The woman who is scheduled for a simpler procedure lands up with an IVF. So this is the reason why we get to MOSI. How does this myoma impact on infertility? There is an encroachment of the tubal ostium and occlusion. There is a distortion of the uterine cavity. Some vascular changes interfere with the normal rhythmic uterine contraction, impaired implantation, abnormal endometrial maturation, altered to oxytocinase activity. All of them contribute to this impact on infertility. You see, there will be a small cavities, what is shown here in the slide. There will be a small cavity, something like what we call it as a caviole in the host myometrium. So if there is a fibromyomata, they are decreased when compared to the normal myometa. What is the problem? So when there is a specific structural abnormality, it may result in calcium metabolism by causing a decrease in defect calcium excretion. So what actually happens? There is a rise in intracellular calcium. If there is a rise in intracellular calcium, it produces myometrial irritability and hyperactivity. So it results in the disruption of the rhythmic contraction process in the junctional zone. So there is a reduced contractile pressure in the fibromyomata, which increases following the myomectomy. These are all the mechanisms there. If there is a subendometrial tumors causing endometrial erosion and subsequent inflammation, altering the nature of the intrauterine fluid, resulting in an old-style environment. They might disrupt the endometrial blood supply, affecting the nadation and then the sustenance of the embryo. The other major problem will be an adenomyosis. It is an enigma or a nightmare for the ART clinician. Treatment, just like how we deal with the fibroid, medical management, surgical, were open, laparoscopic, and robotic. Then came the MRI-focused ultrasound, and now we have an HIFU. So about which we are going to just have a detailed talk. But here again, the plan will be the stimulation and OM pickup with freezing of the embryos, followed by management of adenomyosis prior to the embryo transfer. So you look at the outer myometrium, then you have an inner myometrium, and then there is a junctional zone. This junctional zone is very important entity in the reproduction. And ontogenically, it is related to the endometrium. There are some cyclical changes in the SSH receptors there. It has a very important role in the gamete transport and implantation. And there is some early changes from the time of implantation. Deserialization and trophoblast invasion happens here is very, very important. If it is defective, then probably it results in a spectrum of pregnancy complications like abruptio placenta and abnormal placentation there. This is just to show you the junctional zone, how it appears in different areas. And this is for you to schematically identify. This is a normal junctional zone. And here there is a global adenomyosis. Throughout, there is a uniform thickening of the junctional zone, which is seen by an MRI here. And here you will see in only one area, this is a focal adenomyosis, where you will be able to make it out in an MRI. So these are all different varieties of adenomyosis, which we can know. Now we will see the impact of myoma on infertility. So Jacques Donné's studies, he has seen it, one arm on control, other arm, there is a fibroid with no cavity destruction. And the other side, there is a cavity destructed cavity. You will see in almost all the studies, when compared to the normal, the pregnancy rates has been lesser in no distortion, and it is still lower in the distortion cavity uniformly in all the studies. There is another study by Pritz in 2001 in Obstetric and Gynecological Survey. He has taken about 3 prospective controlled and 8 retrospective control studies, but there is no randomization. Women with otherwise unexplained infertility, location of the fibroids related to the pregnancy, implantation, and deliveries were not calculated there. So in this, the odds ratio for pregnancy is about 0.32 here, with an implantation of 0.2. The same way, after the resection, you will see that it increases to 1.7, implantation increases to 0.9. That shows its result of the myomectomy there. So on conclusion of that with study, subserosal fibroids do not affect the fertility or spontaneous abortion rate. Submucous fibroids lower fertility rates, and myomectomy enhances the rate of conception and live birth. Intramural myoma with or without distortion of the cavity may cause detrimental effect on conception, reaching viability with pregnancy, and effect of the myomectomy is unclear. See, there are conflicting studies here. If you take a submucous fibroid, you will see that in the top study, where it is 3% implantation rate, and the clinical pregnancy rate is 14%, which is much lower. And then there is a spontaneous abortion rate is about 46.7. But whereas there is two studies which I have just quoted here. One says summary of the studies of the IVF model shows the patients with fibroid distorting the cavity have impaired implantation and pregnancy rate. Whereas in the other Taylor study, which shows submucous myoma has a global decrease in the endometrial Hox gene expression, a molecule marker for endometrial receptivity. That is a reason why it should come back. If you take in intramural fibroid, is it a misnomer? It may be classified as an outer myometrium or junctional zone fibroids there. What about its impact on the intramural myoma? There is a plausible mechanism for these fibroids not distorting the cavity has been seen there. However, there is a study by Hart et al. In 2006, and they have just said intramural negatively affects IVF results. However, you will see Inc. study here in Human Reproduction 2002, intramural fibroids do not affect the IVF studies. There are a lot of conflicts there. So the impact when the fibroid is more than 5 centimeters, the implantation dropped from 20 to 11. Ongoing pregnancy rate dropped from 34 to 23. And the pregnancy rate overall dropped from 28 to 15%. So large intramural fibroid negatively affects a pregnancy outcome after an IVF. Large intramural should be removed before IVF. So again, it is beneficial in patients with IVF, but that does not necessarily mean myomectomy should be performed systematically in women trying to conceive, not needing an IVF because of the risk of adhesion formation and myomectomy. So this is not a blanket rule to operate on it. And what about the fibroids which are smaller than 5 centimeters? Should they be disregarded? Should be operated before IVF? Should we operate after the IVF failure? And if so, after how many failures? Or do we operate before any infertility treatment at all? So all of them are queries. Should the decision be influenced according to the cost of the IVF in different countries? Higher the money you pay, you go through all these minor things, correct it, and then come back there. So if it is an intramural fibroid smaller than 5 centimeters, checks reported there is no difference in the implantation rates and pregnancy rates, but they find a lower delivery rate and a higher rate of miscarriages. However, Oliveira studies, which has been published in Fertility Study 2004, no effect on pregnancy rates and no higher incidence of miscarriages. But however, he has just taken only one cycle there. So here in the CALF studies, which has been published in Human Reproduction, you will see if it is less than 5 centimeters, when compared to the control of 32.9, the pregnancy rate has dropped down to 23, and live birth from 24 has dropped down to 14.8. If you see, there is a 40% reduction of success rate in each cycle as they go from cycle to cycle, and if there is an intramural fibroid. So again, if you analyze this, 75 patients with myoma and 127 patients without myoma. So the clinical pregnancy rate is 45 when compared to 53 without myoma. Implantation is 48 when compared to 63 without myoma. And there you will see that the abortion rate is about 40% against 18.9% said. So there is a poor implantation, poor clinical pregnancy, and increased rate of abortion in this myomas there. Here again, you see the number of myomas. If there are less than 3 myomas, the clinical pregnancy rate is about 35. But if it becomes more than 3 myomas, it is about, it results in 28.6%. However, the control is about 41%. And you will see the abortions again, 34.3% if there is less than 3 myomas. If it is more than 3 myomas, it goes as high as about 60% there against the control of about 10. So the pregnancy rate after an IVF in an intramural myoma with various authors, they have just shown it. Definitely, it comes down from the control appreciably there. So these are all the different studies where there is an increase in miscarriage rate after an IVF and if there is an intramural myoma. But what about the impact of the myomectomy and infertility? If you do a laparoscopy, about 51% of them have been with the addition and 30% has been just with an adnexal addition. However, and the laparotomy, there is an increased incidence when compared to laparoscopy on this, according to Dubison study, which has been published in Human Reproduction Update. If you look at the pregnancies after a myoma, so they have taken about 2,065 singleton and compared with the randomly matched birth year and no match for age, parity, and race in term thing. Here, there is an increase in odd ratio for abruptio, first trimester bleeding, and dysfunctional labor, breech presentation, and cesarean delivery. So, in an Israeli population-based study, again, the cesarean rates odds ratio is about 6.7, placental abruptio is 2.6, and prematurity is about 1.34. So, to conclude on this, despite the lack of randomized studies, sharp decline in the pregnancy rates in the submucous myoma is quite convincing, and myomectomy should be performed before ART. It decreases the clinical pregnancy rate, implantation rate, and live birth, and increases the abortion rate. If it is an intramural myoma, it is more controversial, lack of homogeneous opinion, decreased fertility, increased pregnancy loss, and the effect of myomectomy is still questionable. But the consciousness is if there is a myoma of more than 5, advised to operate before ART. If it is less than 5, report outcome varies with no difference, significantly decreased cumulative pregnancy rates there. The controversial final conclusion are probably mainly because of the difference in investigation between the different studies, lack of properly performed investigation, need for a good standardization, evaluation related to distance to and then involvement of the junctional zone, in this case of fibroid, and need to randomize the studies there. So, but if you consider the obstetric outcome, definitely there is an increase in the abruptio placenta, breech presentation, cesarean section, and preterm delivery. And thank you very much for a patient listening. This is with the background, we move on to see how we deal with the fibroid and then how we manage it. And I welcome the next speaker, Dr. KUNDHAVI. And Dr. KUNDHAVI is a senior consultant in Madras Medical Mission. She has got more than 2 decades of clinical experience in ART, and she is going to talk to us on the medical management of these conditions. Over to you, KUNDHAVI.
Sir, thank you for the opportunity.
Dr. KUNDHAVI, please show your PowerPoint. Thank you.
Good evening. Today's talk is going to be on the pre-IVF treatment for fibroids. Is there a role for the medical method? When should the clinician treat a fibroid in women with infertility? The indications for treatment should be established with the care because of the association between fertility and fibroids may not be evident in certain situations. When you look at it, you can really see that this particular group of from 0 to 5 is the main cause of the fertility, myomas and fertility. If you look at the cause, we know that submucous fibroid has got a thicker capsule and uterine cavity distortion, And the others, like intramural, have an impaired blood supply, the gene altered gene expression, and the molecular changes with cytokines and increased uterine contractility, as Dr. Gopinath said. We know that the submucous fibroids do have a cavity distortion and the pregnancy rates come down. And the endometrial and the myometrial blood supply, which is very close to the type 3, probably it interferes with the endometrial blood flow. And the studies have proved that definitely the increase in myoma volume was greater in highly vascular myoma, strongly supporting that the blood supply modifications may affect blastocyst implantation. Let's see whether the medical management do improve this blood supply. Again, the uterine contractility, the intramural myomas induce the abnormal uterine peristalsis, resulting in lower implantation and affecting the surrounding myometrium and lead to increased uterine contractility. And hormonal and molecular changes also, because they modify the gene expressions and significantly impair the gene expression in endometrium. Again, the alteration in the vasoconstriction of spiral arterioles, both the submucous and the intramural myomas, interfere with the uterine contraction and thereby at the level of the functional zone, and we know that it impairs the implantation. And especially this intramural fibroids, which is again a controversial one, because it produces the disruption of the junctional zone, changes in the estrogen and the progesterone receptors, increase in the aromatase, and possible changes in the progesterone receptor, which occurs in the intramural. Probably let's see how the medical management would change these things which could interfere with the fertility. And again, we know that the Hoxha is lower in the submucous as well as the intramural fibroids. So the thing is, the larger fibroids create more of TGF-B, and the TGF-B operates and as a diffuse molecule to alter this BMP expression. So the increase in amount of TGF-B3 probably reaching the cavity, therefore probably interferes with the infertility treatment as well. And we know that the thicker capsule is normally, whether it is an increased pseudocapsule thickness, also boosts the neuroendocrine fiber numbers, but their presence may affect the muscle contractility and uterine peristalsis. Again, the uterine natural cell has also been affected by these fibroids. So the size of the myoma and the proximity, the type 3 myoma measuring 2 centimeters or more, situated very close to the uterine lining, will have a detrimental effect. So when you have a very small fibroid, which may not be accessible by a myomectomy, probably let's see whether the medical management would be beneficial. Again, the type 3 intramural fibroids, we know that it do not significantly increase the clinical miscarriage rate, but it does have an impact when there is about more than 2 centimeters. Again, by the donors, we found that a lot of studies, prospective, nearly 5,000 people, and found that the non-cavity distorting intramural fibroid also do have an adverse effect on the live births. And as Dr. Gopinath said, the junctional zone, it makes a lot of difference in the fertility treatment. And the fibroid that affects the junctional zone. So for this reason, people thought that that is type 4 should be further classified as 4A and 4B. And then 4A probably disrupts the junctional zone and the type 4B does not. So probably there appears to be a sufficient evidence that the intramural fibroid with particular group do affect the fertility. Again, the clinical pregnancy rates, they said that there's not much of difference, but if you have a higher clinical pregnancy rates when the fibroids about more than 5 millimeters away from the endometrial lining, that is very, very crucial. So if you have very small fibroids, how do we deal with the surgery? So such cases, probably the medical management would be beneficial. Sunkratal again said that yes, the live birth rate comes down. As Dr. Gopinath said, there's a cumulative, the live birth rates comes down. So even if it's a smaller fibroids, if you look at in a single cycle, it may not affect, but if you look at the cumulative, it thus brings down the chemistry. So such small fibroids need to be addressed through the medical management. And again, Cochrane, as we all know that not much of evidence by the surgery. So this is something was brought by the donors, a migration effect, whether the medical management, depending on the size and the proximity, whether we could push the size of the fibroid into the myometrium. Let's see whether it is possible. It is obvious that not all fibroids produce infertility, and surgical treatment may be time-consuming, and probably in addition rates are very high. Challenge is which fibroids needs to be removed, how many fibroids, the size, and very close to the proximity as well. So indications of the medical management pre-IVF, probably previous myomectomies, many surgeries in order to avoid another surgery, smaller fibroids less than 2 centimeters, very close to the junctional zone, Intramural fibroids, which abut the endometrium without discharging cavity. When you have all these conditions like recurrent implantation failure or recurrent pregnancy and egg donation program where you have a smaller fibroids or ovarian reserve, not willing for surgery, patients could offer this medical management pre-IVF. And again, we know that 12% do have an intrauterine additions, and oocyte recipients fibroid not discharging the cavity could constitute a risk factor, so probably that needs to be addressed. So again, this is a fertile battle by the Dolman et al. Who discussed that the pros and cons of removal of the symptomatic fibroids. So probably pre-IVF medical management comes into play. We know that the medical adjuvant treatment before surgery for fibroids gives a very good results. Why not pre-IVF? So these are the various drugs being produced, but whereas very few drugs have been resulting good results for the fibroids pre-IVF. That is, you have the selective progesterone receptor modulators, the mifepristone, the GnRH agonist, antagonist. When you talk about the ulipristal, the selective receptor modulator exerts an agonistic and antagonist effect, modulates the progesterone effect on different tissues, effective in reducing the uterine fibroids volume, and this effects last over time. And there's a lot of studies have been found. Very interestingly, people have done a very small studies with 26 patients with submucous fibroids. And what they did was about 3 treatment cycles of ulipristal acid, and they found that 57% of a patient did have a biochemical pregnancy and a volume reduction in 41%. So probably restoration of the uterine cavity may be possible with a single dose of 5 milligrams for 3 months. Again, there's another study, 23 women with symptomatic fibroids, whereas type 1 to type 2, according to the FIBO classification, where they found that and a lot of disturbance, please. So this is a treatment with ulipristal acid. After treatment, they found that the distortion of the cavity reduced in high percentage, about 85%, very surprisingly, with submucous fibroid, and 86% did have a pregnancy test. Another very small group of 13 with treatment with intramural fibroid after a washout period with an ART, and they found that they did have a 61% of positive results. So again, we know that ulipristal represented a non-invasive medical treatment. Fibroids were meant for the IVF, not only women affected by the submucous, but also by the intramural fibroid, which is not distorting the cavity. So single 3 months course of treatment. This is preparing a more favorable environment before ART. Again, we know that it alters the expression of the growth factors, modulates the expression of metalloproteinase by modulating the ratio of progesterone receptor isoforms. We know that ART, ulipristal acetate, could be the best option because it could reduce the fibroid size. Endometrial biopsy did not reveal any histological changes. It was benign, reversible, and without negative consequences. So seems to have a triple effect. Prompt symptom relief, reduces the myomas, improves the morphology of uterus. So what do we want more than this? Again, before we go ahead, if you have a fibroids of more than 4 centimeters, that do not support PIF myomectomy in women with small to moderate size. So probably a valuable information in counseling the women with fibroids because they require probably an increased number of cycles. Again, that if you have a woman with advanced age and prominent intramural fibroid, counsel the patient that you give them 1 or 3 cycles of IVF, aim to cryopreserve 5 to 10 embryos, and then followed by 12 weeks of the ulipristal, and then subsequent FET with their own previously cryopreserved embryos is possible. In the antagon, we know that it improves the bleeding patterns and reduction in the fibroid size as early as 3 weeks because of its rapid onset of action and avoidance of the gonadotropin flare effect. Patients experience faster symptom relief. So antagon could be the choice pre-IVF. We know that the fibroid volume considerably comes down, but without an add-back therapy. With add-back therapy, there was a delay in the reduction in the fibroid volume. So people used various doses of 200 milligrams or 40 milligrams of relugolix, and they found that the reduction in fibroid volume was better. So significant reduction of the myoma and the uterine volume after 12 weeks of 200 milligram was is probably with the antagon practically. At baseline, if you see a fibroid volume of 396 has come down to about 196. Again, the next drug could be an aromatase inhibitor. It blocks the extragonadal conversion of the androgens into estrogen, and this property makes very attractive candidates for the medical treatment of uterine fibroids. And they see that the aromatase is as effective as analogs in shrinkage of the fibroid volume despite stable levels of circulating estrogens as well. So this was a study when compared the letrozole with the agonist, and they found that the letrozole of 2.5 reduced the fibroid cells of 45% when compared to triptyline of only 33%. And this was another study compared the letrozole versus gonadotropin, and they found that the group A received 2.5 for 12 weeks, group B received triptyline, whereas the group A did reduce the fibroid size 45% without the change in the hormones, whereas the group B did reduce only 33% with the reduction in the hormonal size. And these are the drugs which have been used, but again, Cochrane did not conclude to use because the evidence was still insufficient. So conclusion with aromatase, probably the uterine myoma was successfully reduced by the aromatase inhibitors. Probably could be who wants medical management for a transient period, who wish to avoid surgical, specifically women with an unexplained infertility having this sort of myomas. Probably people thought aromatase could be beneficial. The study, there was another study compared the letrozole versus the combination of cabergoline, and they found that 12 weeks of treatment with letrozole with or without cabergoline did improve the size and the volume of the uterus, led to the symptom improvement, and could be used as a short-term treatment prior to the fertility program, again published in 2017. And the cabergoline was well tolerated. This was a study compared the cabergoline along with the analog, and they found that the therapeutic efficacy and fewer side effects, the dopamine agonist may hold a promise as a novel treatment modality for the fibroids. The other study compared the Dynagest 2 milligrams with the leuprolide acetate, and consideration of the GNH disadvantage because of the hypoestrogenic things. And Dynagest probably led to a short or the long-term management who wish to avoid surgical intervention prior to IVF. This is again a latest publication. So coming to the agonist, which most of us use, pre-operative agonist reduces the uterine and fibroid volume. Therapy probably reduces the fibroid for about 35%. So probably before the induction and producing an induction of amenorrhea. It significantly reduces the fibroid volume, the impact on the cavity encroaching the fibroid, and subsequently improve the implantation. Another drug is a mifepristone, where they gave 50 milligram when given bi-weekly doses. It was very safe, and reduce the fibroid to 37%, whereas intramural to 36% and submucous to 33%. The only thing is people were worried is about the endometrial hyperplasia. The systematic review did not support the use of mifepristone. Again, Cochrane did not support the reduce of fibroid volume. Again, a small little word about this adenomyosis. The ultra-long protocol probably had a better benefit before the IVF treatment, and it did improve the clinical pregnancy rates, especially in a diffuse adenomyosis. Whereas another study said that modified down regulation could improve the clinical pregnancy rates by reducing what is modified. That is, they gave the analogs for about 6 weeks to a standard, but down regulation for 1 week prior, and they found this modified had a better chance when compared with the standard ones. But the other controversy was one group said the agonist did not improve the live birth rate as usual, because you know that lots of controversies rising, but most of the patients did benefit with the ultra-long protocol. To conclude the pre-IVF medical management, I would say that pre-IVF diagnosis of the location of the size of the fibroid is very, very crucial. Whether you have a 3D ultrasound or an MRI, patient wish, if they want to avoid the surgery, probably you can give them a medical management. Select a subgroup of population who would benefit. That is, if you have a smaller fibroids very close to the junctional zone, previous patients who had a recurrent implantation failure or previous myomectomy, the choice is probably a very selective group of patients who would benefit from medical management. Counseling prior to the medical management is very crucial. These are the drugs which have got a short-term benefit, as I mentioned earlier, the SPRM, LHRH, antagon, aromatase prior to IVF, reduction in the size, volume, and then an improvement in the endometrial receptivity, and probably an ultra-long GNH agonist or adenomyosis could be offered pre-IVF for the benefit of the patients. And again, I would say that yes, pre-IVF treatment of fibroids is this possible for a selective subgroup of patients. Thank you for the opportunity.
Yeah, Gopinath, Dr. Gopinath. Gopinath, please introduce Korean. Please introduce Dr. Korean.
Hello.
Yes, please introduce Dr. Korean. Thank you.
Hello. This is to introduce another stalwart and a close friend of mine for more than 4 decades, Dr. KURIAN JOSEPH. And he is the generation after generation. His grandfather was a president of the Obstetric and Gynec Society of Southern India, and his father was a president, and then he was a past president, and he has got his name well established in the Asia Oceania as a president. He is a stalwart in endoscopy, not only doing, teaching and training several people all over India and in the overseas countries. So we have Dr. Kurian with us to talk on the laparoscopic management of the fibroids. Can we have the recorded talk, Antonio?
Yes, please. Yes, we will play his course video.
Yeah.
Good day, everybody. Thank you for the kind invitation given to me to deliver this lecture. Special thanks to Professor Gopinath. My topic today is pre-IVF management of fibroids, the surgical aspects only. I bring you greetings from Tamil Nadu, greetings from Chennai, and I show you the beautiful flame lily, which is the state flower of Tamil Nadu. Are we having more fibroids nowadays? That's the big question being faced. Yes, if you ask me, less babies, older age, altered hormonal status, more myomas in the dark skin where we all belong to, the diet, red meat, fried food versus vegetables and fruits, is that also a factor? Whatever it is, we get pictures like this. These were all the fibroids removed from a single uterus. In today's lecture, my brief is simple. Pre-IVF, remove all submucous myomas. Remove large myomas, symptomatic myomas, and cavity distorting myomas. If they are in the borderline, to remove or not, or to suppress, again is a question mark. If pathology is unclear, remove, biopsy, and decide. The final decision will be made between the doctor and the patient. So, with that, the first is to study the effect of myomas on IVF. The effect of leiomyomas on IVF is dependent on its location. Submucous myomas decrease success, whereas subserosal myomas do not seem to have any effect. The effect of the intramural myoma is unclear, and I'm sure Professor Selva would go greater into detail in his lecture. But the meta-analysis showed that there is a definite decrease in the live birth and clinical pregnancy rates in women with non-cavity distorting intramural fibroids compared to those with fibroids. But to treat fibroids, the first step is to classify them. This is where the FIGO classification comes into play. But studies of the FIGO classification on 23 patients with 42 fibroids showed that only 6, that is 14%, had unanimous classification, telling us that the classification was not consistent among the 4 fibroid specialists, and the variation was clinically significant for 36% of the fibroids. So we need more additional validation. But whatever it is, we must locate it. And to diagnose the location of the myoma, traditionally we use the HSG, the ultrasonography, and Doppler are the prime tools used nowadays. But increasingly, we find the MRI scan more helpful, especially in situations like this, where you have multiple myomas. You have a good reproducible picture which can be used effectively in theaters. Whatever it is, the importance of proper diagnosis and consent before the procedure is vital. You see this case of a bicornuate uterus, well-developed right horn. There's a big fibroid on the left horn, and there's a small rudimentary horn. The importance of proper diagnosis is, do we have a consent to excise the rudimentary horn at myomectomy? So once you have located the myoma, then you decide on the procedure. There is a role for conservative treatment. Take the case of this 37-year-old married for 9 years, now preparing for IVF. She has had a previous lap myomectomy. She has had a hysteroscopic myomectomy. She has a large uterus with multiple myomas now. The MRI findings, as you can see in the picture, are seen clearly. The option, do you do another myomectomy or do we do another procedure? So what we did in this case was, with discussion with the patient, did a hysteroscopy, located the polyp, removed the polyp, and then down-regulated her and took her for IVF. There was really no role for curettage and no role for repeat myomectomy. When surgery is decided, you have multiple operations. Traditionally, we had the open surgery. Later, it became mini laparotomy. To today's favorite, the minimal access or the laparoscopic surgery. Other variations like single port surgery, NOTES, robotic surgery are all there. But with regard to removal of myomas, hysteroscopic myoma is extremely vital and extremely useful, especially in the in the IVF context. So surgery still remains the mainstay of treating myoma. When we have submucous myomas, remember that they significantly reduce implantation and pregnancy rates of ART. Submucosal fibroids that distort the uterine cavity have found to carry a relative risk of 0.3 for pregnancy and 0.28 for implantation after ART. Also, with the submucous myoma, the odds ratio of 0.3 for conception and 0.3 for delivery make sure that the incidence that if there is a submucous myoma, it must be removed. To remove, first you locate the myoma, decide on the type of the myoma. Type 0, type 1, and type 2 could be removed easily hysteroscopically. But if the myoma is large, or it is type 3, then is there a role for GnRH analogs to shrink the myomas to below 6 centimeters? It is controversial. Get the consent for a true stage procedure. If needed, laparoscopy also, or conversion to laparotomy. Check the setup, soften the cervix to introduce the resectoscope, use vasopressin injection, and check up the entire setup routinely before every procedure. At hysteroscopic myomectomy, resection of submucous myomas offer minimal complications and rapid recovery. Few reported cases of uterine rupture with this technique have been reported, and intrauterine adhesions could occur. Patients could even attempt a vaginal delivery. So what is done here is basically a procedure using the bipolar resectoscope, using normal saline as medium. The resectoscope goes in, myoma is identified, and you go and shell it out. Variants of the procedure using the hysteroscopic morcellator also have been reported, but the big problem with the morcellator is, one, it's cost, and the next problem we have with the morcellator is it is difficult to remove intramural extensions of submucous myomas. So the myoma is carefully removed, and you get to a final picture where the cavity is nice and clear with no myomatous elements seen in the myometrium. But whenever you're treating any myoma before IVF, remember you have a special class of patients. Most of these patients are older. Many of these patients have associated comorbidities. Some have SLE, some have hypertension, diabetes, obesity. Remember, many of them would have had previous surgery. Ovarian reserve may be low, and associated gynec conditions may occur, commonly adenomyosis and very often endometriosis. The cost of the procedure is a factor, especially in developing countries, and the time available to carry out the procedure is limited because these are mostly working women. The decision of the route of surgery for removing a fibroid is very, very complex and has to be decided by the surgeon with the patient. Like the simple picture shows you three women carrying the same pot in different styles. The same way this fibroid could be removed out of the patient in different styles, be it open surgery, be it laparoscopy, robotic, or whatever options. Let's go through a simple case of a 32-year-old woman with a large posterior cervical myoma with about 8 into 8 centimeters, who's planned for IVF. You inject vasopressin, go in, incise, get into the plane of the myoma, shell out the myoma, be careful not to traumatize or close down the cervical canal. Once the myoma is removed, the cavity is sutured carefully. So this is the standard procedure, extremely rewarding, surgery uneventful, and IVF could be planned after 4 months. Many operative decisions have to be made. The site of the incision, whether there should be tunneling or not. Today, tunneling is generally not done. The horizontal versus the vertical incision, the direction of traction. If the endometrial cavity has been opened, don't be worried. Suture the myometrium properly. The endometrium will form the lining again. The most important principle of any of these surgical procedures is primum non nocere. First, do no harm. We may be able to treat small to big, solid to cystic, cellular, vascular, and calcified tumors with this. Here you see a large 8 to 9 centimeter myoma, which is essentially in the broad ligament. And you can see you get into the plane of the myoma, shell out the myoma, and as you shell it out, you realize that the myoma goes deep into the broad ligament. You can notice that the bleeding hardly occurs, and once you shell out the entire myoma, it is soft, it is cystic, and then to take it out, how to do it? We took it out in this case vaginally. So these are the options which are available to do a nice, simple, clean procedure so that the patient could be there to ready to undergo ART as soon as possible. But don't overdo your technique. Plan the steps for a procedure well. Common sense is essential. The simple principle, we believe, keep it safe and simple, or as they say, the KISS principle. There is a swing on the edge of a cliff in Ecuador. It has no safety measures and is also called the swing at the end of the world. But unlike this, we must have safety measures for the patient, the doctor, and for the procedure. Set up quality equipment, follow guidelines, do a complete procedure, and if in doubt, cross-check. Remember, the era of the Wild West in surgery, those days are over. But still we have problems with surgery. Surgery may vary from case to case, the complexity, complications occur, recurrence, and sometimes it is technically demanding. Take the case of this 29-year-old with a large myoma on the posterior wall of the uterus. The surgeon decided to put a posterior incision, and at the incision, they decided to put a horizontal incision out, converted it into a hockey stick incision, and in short, the dissection became messy, planes became difficult, and surgery became difficult. So these are the things with bad planning. Remember also that whenever you finish surgery, the histopathology of the myoma has to be carefully assessed as a benign myoma or a cellular myoma, because occasionally you may have smooth muscle tumors of uncertain malignant potential and very rarely a leiomyosarcoma. So the need for an expert pathologist, and if there is anything, follow up carefully. Sometimes we get the picture of multiple myomas in a young woman. A 24-year-old with unmarried came with multiple myomas. She had had all the procedures we could list out: open myomectomy, uterine artery occlusion, GnRH analogs, MRI guided. She got married. She had no symptomatic relief, and now on ultrasound, the uterus was around 20 weeks with multiple myomas. These are the difficult propositions. You do a difficult myomectomy, keep the uterus in a quiescent stage, prepare her for IVF, and then do it. But in a situation like this, one really can't prevent recurrence, and what her future will be is a problem. Occasionally, we have pictures like this 31-year-old recently married who was suggested for IVF. She had had 2 previous laparoscopic myomectomies, had a recurrence in 2021, a 20-week uterus with a large growth on the anterior left lateral wall. The growth looked suspicious at scan and MRI, so we did a PET scan, and that suggested a malignancy, possibly a sarcoma. The malignant mass was found. She was referred to an oncologist who had to finally do a hysterectomy for her. So what are the results of IVF after myomectomy? A study compared 84 women who had myomectomy before IVF with 84 women who did IVF without surgery. The myomectomy group had a 25% delivery rate and a clinical pregnancy rate of 33% versus just 12 and 15 in the non-surgical group. Hence, myomectomy before ART improved pregnancy in infertile patients with submucosal myomas and intramural myomas. In subserous myomas, myomectomy before ART did not affect pregnancy outcomes. So in conclusion, in management of myomas before IVF, choose carefully, plan wisely, assess options, and operate correctly, resulting in a happy patient and in a happy doctor. I hope you will accept the challenge of the myomas. Thank you all for your kind invitation. And smile. It's infectious and spreads. I know you're all itching to do this, but remember that that's just an autumn leaf that fell on the sidewalk and made the most beautiful smile. Thank you very much.
Thank you, Kurian. Thank you for sharing your experience, skills, and knowledge on the myomas. And we always believe that when we try to do any laparoscopy, the laparoscopy is an instrument, and it is just to say it is a magician who always does the trick, and magic wand is only a wooden stick. So you are performing magic with your laparoscope, and then we could really see the results. We will move on to the next speaker. Again, a stalwart, Dr. Aili. She has started from days of the open surgery, and then gradually she moved on. She had one of the best medical education, and then higher training, and then she is one of the finest doctors who have crossed all the milestones. And I had an opportunity to talk with her yesterday, and it was such a pleasant person, and you will believe and you will hear from her soon. She has had extensive experience on non-invasive medicine, and then she is a member of Uterine Fibroids Management Subcommittee in the Chinese Medical Doctors Association. She is a deputy head medical group of endometriosis management, Shanghai Medical Association. She is from Shanghai, and she is going to talk to us on the management of adenomyosis. Over to you, Aili.
Thank you so much, Professor Gopinath. Firstly, I want to thank your kind invitation, and good evening, all friends from India. Firstly, I want to share, I have a beautiful links with India. The first thing is when I was young, there are a lot of people always say I looks like an Indian, but that is happened when I was young. And the second thing is in 2009, the two doctors I studied with Cameron Izad in Stanford University of US. The two doctors are Indian. One of them, whose name is Sumati Kutikila. She is treat me so nice, and he helped me to find a place to live. So I remember it forever. So also, she always take us to see and to enjoy different culture, including the Indian cuisine, Indian food. I love it. I feel Indian food is very delicious. And the third, the link is here. So from this picture, we can see the several doctors here. So maybe before the pandemic, several years ago, due to the conflict in my schedule, I was not able to see them, but I arranged this visiting. So they leave the pictures to my colleague. They are from, I'm not sure whether these three handsome boy, today in this webinar or not. Professor GOPINATH, the three doctors from India. So today my topic is about adenomyosis treatment. So first, adenomyosis, all we know, it's a very hardest disease. Also, like Professor Govina mentioned, it's enigma. So the three hard things, one is complex pathogenesis. The first case was found in 1816 by Rokitansky. So it already coming through more than 1 century and a half, but we still do not know what is the true reason about the adenomyosis. The second hard thing is very difficult to treat, except hysterectomy, especially related with IVF. Like Professor Gopinath said, it's really a very difficult disease. The third hard thing is high recurrent. And this disease, the incidence is much higher than we know. Like yesterday I talked about with Professor Gopinath, the incidence much higher than in the data in the magazine. The patients is getting younger. So here we can see the patients only 16 years old, unmarried girl presented to us with acute episodic pain in the left lower abdomen. The pain was severe in nature and occurred every 2 or 3 months for last 3 years. So now the young girls already have menstruation at their very young age, sometimes less than 12 years old. Like this girl, 16 years old, already had 3 years pain, so she has his menarche at 13 years. Her menstrual cycle were regular with an average flow. He had severe dysmenorrhea. She required analgesic for pain relief. She had already undergone ultrasound and MRI. Here we can see the MRI, the endometriotic lesion. And from 3D ultrasound can clearly see the lesions here. And through laparoscopy, so we can see the lesions here. So the mechanism about adenomyosis are also very complicated. So this is from Professor Chaperon, who is the president of Endometriosis Society in the up-to-date. And he mentioned in his slide, uterine construction and the hyperperistalsis cause the efflux of endometrium into the peritoneal cavity and contribute to implantation of endometrial tissue and the formation of endometrium lesion at ectopic site, resulting the development of three common types, SUP, OMA, and some DIE. Part of the rectovaginal DIE is derived from the metaplasia or Mullerian remnant. Extrinsic adenomyosis may arise secondarily through pelvic adenomyosis. Here he mentioned a very interesting type, FAOM, focal adenomyosis outer myometrium, can result from rectal and bladder DIE. Evidence suggests that SUP, OMA, and extrinsic adenomyosis occur in relatively young women and show TGF-dependent fibrosis. The RETRAR and the EMID hypothesis show uterine construction also induced microtrauma at the EMI, leading to intrinsic adenomyosis with time. So the two types are coming from two different mechanisms. Intrinsic adenomyosis is frequently found in women in the transitional period of menopause and show TGF-independent fibrosis. The mechanism of fibrogenesis may differ depending on the site of the lesion and the time course. So this is a new one. And I want to mention that the very close relationship between IVF and adenomyosis. There are so many guidelines and data and investigation, so they had a close relationship. Especially from Chaperon's new paper here, focus adenomyosis is significantly and dependently associated with infertility, especially primary infertility. About adenomyosis management, very important thing is depending on patient's intention and priority. Second is clinical symptoms include AOB and pelvic pain. The patients come to us, the big reason is pain. The second is anemia. And third is infertility. Adenomyosis phenotype, infertility history or desire of pregnancy, also very important. Associated endometriosis, nearly 50% of adenomyosis associated with SUP, OMA, DIE, or endometrial polyp. Associated other disease like polyp, myoma, some kind of pound coin classification. So here's a clue for our treatment. AOB and adenomyosis. Here we focus on infertility. If the patient have very severe anemia, the first thing should inhibit menstruation and improve hemoglobin. If not spontaneously pregnant, we should seek the help from the doctors, like part of you may be the reproductive doctors doing to help the patient pregnant very soon. The HIFU after 2 ART failure can be choice definitely. And if the patient have no severe anemia, usually we will depending on the desiration for pregnancy. If the patient without the desiration, we will choose the size of the lesion. If the lesion larger than 3 centimeters, we will begin 3-step therapy, HIFU, medical treatment, and TCRE plus Mirena. If the patient, the lesion less than 3 centimeters, we can directly go to TCRE and the Mirena. So here, I want to say all roads leads to Rome. So we can choose any kind of medication. Dynogest is a very new oral medication for adenomyosis. So this is our cases. This patient wouldn't like to choose any kind of operation, even HIFU. So she would like to accept the medication. So very important thing, you should follow the patient's psychologically motivation. After 8 months, we can see posterior endometriotic lesion smaller, shrink more, and the patients relieve the pain. And we have many patients with big cyst, OMA, chocolate cyst. So usually this kind of patient, we will combine with laparoscopic surgery. Also, sometimes if the patient has polyp or submucous myoma, we also combined with hysteroscopic surgery. So about the big chocolate cyst, we will choose 4 steps for laparoscopic skill. The first thing, absorb the liquid completely. And the second, do hydrodissection. Hydrodissection technique we learned from our professor from Stanford University, Cameron Nizat professor. He liked to everything hydrodix, put water inside, even the very small cysts, very small peritoneal endometriosis. He good at to use this technique. And the third step, drilling the very gently to protect the normal tissue, normal ovary tissue. The first step is coagulate gently. For the very big lesion, for diffuse adenomyosis, usually we choose these 3 steps. We already mentioned this many times. I guess some of the doctor already heard it before. Step by step, first is HIFU and then use GNRH or any types of medication. And third step is Marina. So we published this paper in 2019. So we had at that time we concluded nearly 200, more than 200 patients. From this picture, we can see posterior adenomyosis. 1 day after HIFU, we can see the ablation area. And only 80 days after HIFU, we can see the beautiful size of the uterus. So we surprised with the beauty of this non-invasive HIFU technique. So I wrote this sentence, as magical as a work of art. The normal uterus inside the pelvic wall is like turnip, the beautiful flower, and the uterus size can be changed if the lesion disappear, including myoma. So we compare the patients through VAS score. Here we can see after HIFU 3 months, 6 months, 12 months, the C1 to 5 level and the VAS score, the very getting the good level. Also the menstrual volume score decreased dramatically, including uterine volume. We can see here just after 3 months, like the case I mentioned, only 18 days coming to the normal size. 3 months, 6 months, and 12 months, the uterine volume was compared before after HIFU treatment. The uterine volume was significantly reduced after HIFU ablation. Hemoglobin level also increased dramatically. The very standard traditional CA125 also can dramatically reduce the just eye after HIFU. It's like magic. So our conclusion about these 3 steps, it has safe and effective and efficient. It can improve the quality of life of the patient, especially with the patient localized adenomyosis. Here I want to share some specific cases. These patients, 41 years old, she has 19 years of progressive dysmenorrhea, very typical symptom, and the menorrhagia more than 7 years. BS score 7 to 8, and also like 3 months pregnant, and the hemoglobin 94, C125 278, anterior uterus, the lesion side 76 millimeter, posterior wall, we can see here, posterior wall and adenomyotic lesion. The treatment plan is GnRH, HIFU, Dynagels, and TCRE, and Mirena. Actually, this patient had 5-time injection in another hospital already. So we follow this treatment curve that give the HIFU in 2020, the April, and after HIFU, the patient wouldn't like accept the GnRH again because she had many side effects. So she want to choose the oral medication, Dynagels. And then nearly after 1 year, the size of the uterus nearly coming normal. So we give the TCRE, shaving all the endometrium out and put Mirena in. Here is the picture. So before HIFU, we can see the posterior adenomyotic lesions, and after HIFU, we can see the ablation area. This is a TCRE video for very easy. So I saw you are all good surgeon to laparoscopic and the hysteroscopic surgery, shaving the old endometrium out. And now the patient have no menstruation and she feel happy. So our proposed treatment protocol combined HIFU medication and TCRE and Mirena for the patient without pregnancy desiration. So that is combination therapy. HIFU also will not influence the ovary reserve. The pregnancy outcome of endometriosis patients treated with HIFU, the effect is good. Here is a paper published by one of our very famous professor in China, 78 patients. And this is a retrospective observational study. In our center, we have more than 50% patients with adenomyosis. Here we can see the patient's age less than 14, nearly half, more than half. And we already have nearly 100 people pregnant, 19th IVF, because this patient already had planned in the IVF center. So we have very nice cooperation with IVF center, also with obstetric department. We cooperate together. So we finish the HIFU, we send the patient back to the IVF center. So we have several cases, filled several times in IVF center after HIFU treatment and easily pregnant. The first time get successful result. And we have another patient, they want to naturally pregnancy and all the results are good. There are no rupture. There are no uterine rupture happen. So this is a patient, cases pregnant, 38 years old, 6 years progressive dysmenorrhea, the lesion size nearly 5 centimeter posterior wall. Treatment plan, embryo frozen first. So this is a very important. We should discuss with IVF doctors and patient and family. Frozen embryo first and do HIFU, and then give GnRH and then IVF. The pregnancy outcome is very good. No obstetric complication, full-term cesarean section, but it will depending on the obstetrician and patient situation. It will not related with HIFU surgery. So here we can see the patient's procedure clearly, embryo frozen and then HIFU, and we give 3 injections. Actually, the patient had normal size of uterus after 3 months. Because of the family reason, the patient get pregnant 1 year later. So here we can see the posterior adenomyosis, the lesion, the ablation area. From the last picture, we can see endometrial line is beautifully recovered. So very important thing, the HIFU can improve the endometrial environment. The environment is very important for IVF. So our summary, effective treatment of symptomatic adenomyosis require classification of the disease. Adenomyosis negatively impact fertility and obstetric outcome. Surgical myomectomy has a risk of surgical complications that may lead to obstetric risk. So I have colleagues who do laparoscopically surgery. The patient's happened rupture at her 32 months. The baby died. That is really sad story. And it also happened in another hospital. I heard the 8 cases in 1 year. But our HIFU never happened rupture. HIFU has the advantage of non-invasive, favorable safety profile, quick recovery, and retreat capability. So adenomyosis is a very complicated disease, also the chronic disease uncurable. So we will not expect after HIFU stop any treatment. The lesion will come back again. So we should tell the patient before HIFU. After HIFU, we will continue to control the lesion up to the menopause. Like a pelvic vampire, no menopause, no menstruation, no adenomyosis. We should waiting for the menopause. So HIFU can selectively ablate the concentrated granular muscular lesion, reduce the scope of the lesion, and abrogate the function of the ectopic endometrium so as to improve the symptoms such as dysmenorrhea, heavy menstruation, and the uterine environments. That is very important to IVF. A combination approach, HIFU and medication, is required for the effective management of adenomyosis. HIFU may be particularly suited for patients with pregnancy desire, but require more clinical study. We are doing study now. And like Professor Gopinath mentioned, I am beginning my career with laparotomy, open surgery. And from 2000, I begin my laparoscopic journey. And from 2015, I am still young for HIFU surgery. Actually, our cases just more than 2,000. But in some center, that is 20,000 maybe in Sweden and somewhere. But our cases focus on adenomyosis. So I have many excellent teachers like Cameron Izzat, Peter Ma, Felix Wang. All they are famous in the laparoscopic area. And in China, we have very different medical system. We usually work in the public hospital, everything controlled with the government. We seldom go to private hospital, or we can't have established our private center. So we should depending on teamwork. We should build a team, can develop any tactic growing healthily. So I have my team here. Totally, we have 5 doctors can performing HIFU. And I also had 2 doctors follow me doing laparoscopic surgery. And this is the autumn season here. So I want to show my hometown, Xinjiang. I'm in Shanghai, Xinjiang in the western part, the beautiful autumn landscape. I hope after this discussing pandemic, welcome to visit my hometown. And I also want to say the thanks to Professor Gopinath again. Thanks for your invitation. And I check a little bit the thing today to learn some culture about the India. I want to end my lecture with these words. that is from your very famous writer. When we help others, the universe will help us back. Thanks again. All the best for all of you.
Thank you,
Thank
Dr.
you.
Aili. Thank you for the wonderful talk. You started with the micromanagement and then the pathogenesis of adenomyosis from a totally different view. And then you just manage them differently with different scenarios for patients seeking pregnancy, patient not seeking pregnancy, combining both the medical and then non-medical and then HIFU all put together. You have given a global view of the management of adenomyosis. Thank you very much for sharing your experience. And
My
we'll wait for
pleasure.
the question and answer, and then we will just get back to you.
Okay.
It's my
Thank you.
pleasant duty to introduce yet another friend of mine, Dr. Selva Raja. We popularly call him as Selva. So you will see here, even as the name suggests, Selva Raja Subramaniam, he's a Superman. he is a general gynecologist, laparoscopic surgeon like any of us, like he has moved over and then he has been a past president of APAGE, the Obstetric and Gynec Society of Malaysia, and currently in chair in endoscopic subcommittee and is involved in promoting gynecological endoscopic surgery in Malaysia. He is from a very lovely hometown of Malacca, and he is going to talk to us now. Over to you, Selva.
Thank you, Dr. Gopinath. Let me see whether I can share my screen. Can you see my screen?
A part of it.
Is it? Can you see it now?
No, full screen is not. Can you just
escape first?
Stop screening and then again share.
Yeah. Okay. I'll. It's not. I stop share first and share again. All right. 1 second. I get to Zoom. Let me share again. How is it looking now? Better?
That's right. Fine.
Okay. Thank you.
Fine.
Thank you, Gopinath. We had a good time in Chongqing, I think, in 2019. And I met a nice dinner. So I have been asked to speak on this topic called intramural fibroid and fertility to operate or not. And I must say that my job has been made easy because the first two speakers, Dr. Gopinath, Professor Gopinath and Dr. KUNDHAVI, has already touched most of the things that I'm going to say. But since I've prepared the lecture, I'll still speak on this topic. Now, we all know that uterine fibroid is a commonest monoclonal tumor in the women. It is also the sole cause of infertility, probably in 2 to 3% of women. Current literature shows that, Current literature shows that calls for removal of submucous fibroids and possibly cavity distorting fibroids. Okay, cavity distorting fibroids. But to optimize pregnancy outcome. But however, the removal of non-cavity distorting intramural fibroid is still controversial. I think Dr. KUNDHAVI has touched on this. Even Dr. Gopinath has touched on this. And what is a non-cavity distorting intramural fibroid? These are the small fibroids that are in the myometrium. They do not distort the cavity, but they are there and the patient is not getting pregnant. For example, this kind of fibroids. It is a 3D photograph of a fibroid. Now, are these fibroids going to cause infertility? And are we going to do something about it? That is going to be my talk today. Now, what is my lecture outline? My lecture outline is what are the classifications of fibroids? What is the pathophysiology that causes subfertility in patients with intramural non-cavity distorting fibroids? Some of it has already been touched by the previous speakers. Does intramural fibroid cause infertility? Also touched in the previous lectures. And does myomectomy improve pregnancy rates? And are there alternatives to myomectomy in these patients? Also has been touched, and I will touch more on this. And to tell you all, this is actually based on a review paper that I've written some 2 years ago, and it is published in this paper. You can get this paper, and the details of what I'm going to say is from this paper. Now, the first question is, how do we classify fibroids? Now, we know that fibroids are, the traditional classification is that it is submucous fibroid, subserosal fibroid, intramural fibroid, and cervical fibroid. And we have this FIGO classification, which we are all very familiar with. We also know that 1, 2, 0, 1 are complete submucous fibroids. Nobody questions that we need to remove this if the patient wants to get pregnant, whether normally or by IVF. Even type 2, even if it is a large percentage of the fibroid is intramural and only a small percentage is in the cavity, it is still classified as submucous fibroid, and this also have to come out. There's no question about that. As far as subserous fibroid, that is number 7, number 6, and number 5, there is enough evidence to say that we probably don't have to remove them, and the patient probably can get pregnant unless the patient is so large that it's going to interfere with the pregnancy. Then we need to remove. There is a category called 2 to 5, which is patients with fibroid that the thickness of the fibroid on average is about maybe 3 to 4 centimeters. And if you have a 3 centimeter fibroid, it is going to somehow go into the cavity or go outside. And that's the reason why we have these 2 to 5. And these 2 to 5 probably need to be removed. So my interest is in these 2 types, which is type 3 and type 4. I think there's enough evidence to say that if you have type 3 fibroid, which is the fibroid that's touching the endometrial cavity, then that has to come out, however small it is. Type 4 is the one that does not touch the endometrial cavity, and this is the intramural non-cavity distorting fibroid that I am going to talk about. What are we going to do about it? And as I said, the 2 previous speakers have touched on it. I'll try and elaborate on it, summarize on it, and then see what we can conclude from here. So this, for example, this is an example of a patient with a subserous fibroid. The patient is happily pregnant and she delivered the baby. So there's no problem with these subserous fibroids. Now let's look at pathophysiology. Again, this has already been touched, but I'm going to summarize the different pathophysiology, why these small intramural fibroids can cause fertility. But many women with intramural fibroids, small ones, get pregnant, but some of them don't. Why is that so? And these are the things that I wanted to discuss. And the problems are, these are different problems that can occur. There may be a problem with implantation. There may be a problem with the junctional zone. There may be uterine myometrial peristalsis, a problem with fibroid pseudocapsule and steroid hormone. Some of it have already, as I said, has been touched. What about implantation? Now, implantation we know is a complex process. Factors, which is HOXA10, glycodelin, leukemia, inhibitory factors, glutathione peroxidase, all these are factors that affect. And we know that HOXA10 is responsible for cellular differentiation, while glycodelin is responsible for promoting angiogenesis and suppressing natural killer cells and inhibiting the binding of spermatozoa to zona pellucida. So normally both factors are reduced during the follicular phase and increased during the implantation phase for implantation to occur. So it is said that patients with intramural fibroids, both HOXA10 and glycodelin are reduced during implantation. This may be the factor that affects implantation on patients with intramural fibroids. So this is one of the theories. If you have an intramural fibroid, because of the reduction of these factors, implantation does not occur. But the problem is we can't do anything about it. We don't have anything that can improve this implantation with patients with intramural fibroid. Now, the next is junctional zone. Now, we all know, as is shown very clearly by the previous speakers, that there is something called a junctional zone, and there is something called uterine peristalsis. And this uterine peristalsis actually originates in the junctional zone. And disruption of the junctional zone by fibrosis can lead to increased peristalsis. Thickening of the junctional zone caused by intramural fibroids is also poor reproductive outcome. So natural killer cells were reduced and macrophages increased in the endometrium closer to the fibroid compared to other areas. So if there is a fibroid and it's close to this junctional zone, then this may increase peristalsis and also may cause all these factors to be increased. So that may be another factor that affects poor reproductive outcome in patients with small intramural fibroid. Now, because of that, Dr. KUNDHAVI has mentioned this. I actually proposed that we should actually classify type 4 fibroids into 2 types, which is type 4A and type 4B. Type 4A are the fibroids that touches the junctional zone, and type 4B does not touch the junctional zone. Probably type 4A will have a much bigger effect on fertility than type 4B. So what about myometrial peristalsis? There are actually two types of uterine contractions. The first is the focal and sporadic bulging of the myometrium, and this is probably not very important, but what is more important is the rhythmic and subtle stripping movement in the subendometrial myometrium, and this is called uterine peristalsis. Now, we all know there's such thing called uterine peristalsis. The only problem is how to look for it and how to treat it. That is a big problem. So uterine peristalsis is captured by cine MRI. Now, this cine MRI is a complex process. You need to do repeated MRIs, and from that MRI, look for movement, peristalsis, and this is the best way of determining uterine peristalsis. And here you can see an example of uterine peristalsis captured by cine MRI. Now, from menstruation to mid-ovulatory phase of the menstrual cycle, the uterus contracts from the cervix to the fundus with increasing frequency. This is a factor that helps propagation of the movement of the spermatozoa from the cervix into the uterine cavity and into the fallopian tube. Post-ovulation, the contraction frequency decreases to relatively quiet during implantation, so that implantation will take place. And in the luteal phase, the direction of the peristalsis is actually reversed. So uterine peristalsis is increased in patients with intramural and submucous fibroids during the mid-luteal phase and decreased during the peri-ovulatory phase. And this is shown very clearly by this paper by Yoshino, and I will try to describe this interesting paper that is done by Dr. Yoshino. Now, what he did is that he took 95 infertile patients with uterine fibroids and then did MRI on them. The inclusion criteria were as follows: presence of intramural fibroid, he excluded submucous fibroid, no other significant infertility excluding endometriosis, regular menstrual cycle, MRI performed at the time of implantation, and the frequency of the junctional zone movement were evaluated using cine MRI. And after MRI, the patient underwent infertility treatment for 4 months, and pregnancy was evaluated. This infertility treatment was a normal infertility treatment, no IVF. So what he got is that 51 patients fulfilled his criteria. Out of that, 29 patients, 57%, and 22 patients, 43%, were assigned to low and high frequency. So you have 29 patients with low frequency and 22 patients with high frequency. Now, how we define frequency is that if there is 0 or 1 movement per 3 minutes, then he classified that as low frequency. And if there is 2 or more in 3 minutes, then he classified them at high frequency peristalsis. So what happened is that 10 out of the 29 patients in the low frequency group actually achieved pregnancy, that is 34%, whereas none of the 22 patients in the high frequency group achieved pregnancy. So he concluded that if the patient has a small intramural fibroid and the patient has got high frequency, then the chances of them getting pregnant will be lesser. So the factor here is the uterine peristalsis. So this is a conclusion: a higher frequency of uterine peristalsis during the mid-luteal phase might be one of the causes of infertility associated with intramural type of fibroids. So next, let's look at fibroid pseudocapsule. Now, we all know that the fibroid has got a capsule, and this capsule is actually important because it contains smooth muscles and neurotransmitters. It is highly vascular, is upregulated by endogolin and CD34, and the PC thickness varies in the type and location of the fibroid. Is thicker in the submucous fibroid compared to intramural fibroid, compared to subserous fibroid. Cervical fibroid has the thickest pseudocapsule. The presence of pseudocapsule with its cytokines, growth factors, and hormones may be responsible for abnormal uterine peristalsis, which may cause premature deliveries in women with intramural fibroids. So neurotransmitters in pseudocapsule is important in promoting inflammation and proper wound healing. So it is important to do intracapsular myomectomy without excising the pseudocapsule to reduce intraoperative blood loss. We all know that when we do laparoscopic surgery and open surgery, to enhance better uterine healing and correct musculature anatomical restoration to preserve uterine functionality for reproductive purpose. So the pseudocapsule might play a role in infertility, but we do not know how to solve it. So next is steroid hormone. This has also been touched in the earlier speakers. Fibroid tissue contain high concentration of aromatase, estrogen receptors alpha and beta, and progesterone receptors compared to surrounding healthy myometrium. Fibroid is known as estrogen dependent. We all know that. And this study by Ishikawa have shown that both estrogen and progesterone are responsible for fibroid growth and maintenance. So we all thought that only estrogen is the predominant cause of uterine growth, but it's not actually. In his study, he showed that high estrogen level actually stimulates the junctional zone and induces rapid uterine contraction, and progesterone antagonizes its effect and suppresses uterine contractility. We all know that because when we do IVF, we suppress the uterus by giving progesterone in the luteal phase. So let's look at now, does intramural non-cavity distorting fibroid cause infertility? Again, this has been covered earlier. Now, if you look at the literature, there is a group that says, yes, intramural fibroid reduce fertility outcome. You can look at a lot of papers, and there is another group of studies that says that intramural fibroid does not have an effect on infertility. So when we have this kind of contradicting results, then we look at some kind of meta-analysis. First is this Sunkara's paper, which has already been touched by two previous speakers. Sunkara actually looked at the effect of intramural fibroids without uterine cavity involvement on the outcome of IVF treatment, a systematic review and meta-analysis, and she concluded that the presence of non-cavity distorting fibroid is associated with adverse pregnancy outcome in women undergoing IVF treatment. This is also touched by another speaker earlier. This is another paper, more recent one. Again, it is the impact of non-cavity distorting intramural fibroid on efficacy of IVF and updated meta-analysis. And here, this paper concluded that the present evidence suggests that non-cavity distorting intramural fibroids would significantly reduce the clinical pregnancy rate and live birth rate after IVF. Significantly increase the ectopic pregnancy rate. So now we can say that a non-cavity distorting fibroid probably affects pregnancy, and probably there will be a decrease in IVF pregnancy rates if the patient has got an intramural fibroid. But the question asked is, does myomectomy improve pregnancy rate? So there again, the literature is divided. We have got a group of doctors who say that yes, myomectomy will improve pregnancy rates, and there is a group of doctors who say no, myomectomy is not advisable. Now, again, we'll look at this gentleman called Yoshino, who actually told you all, whom I mentioned earlier, did this interesting study to show that if the patient has got increased uterine peristalsis with an intramural fibroid, then it will decrease pregnancy rate. So what he did is that he took the patients, remember the patients that had increased peristalsis and none of them had pregnancy rate. He took them and he took 15 of them with frequency of the uterine peristalsis and then did a myomectomy on them. And it found that out of them, 14 patients had normalized their peristalsis following myomectomy, and the second MRI test, and 6 out of the patient achieved pregnancy. So he concluded that if the patient has uterine fibroids and if they have abnormal uterine peristalsis leading to infertility, then myomectomy may improve infertility in these patients. So what have we come so far? Now, what I've told you all is that probably there is enough evidence to say that small intramural fibroids actually decreases pregnancy rates, but when there is intramural fibroids, when the intramural fibroid causes an increase in uterine peristalsis, pregnancy rate decreases. So not all patients with intramural fibroids will have a decreased pregnancy rate, but those with uterine peristalsis that is higher will have a lower pregnancy rate. The only problem is that we are unsure whether myomectomy in these patients improve the pregnancy rate, except if they have got increased uterine peristalsis. So if there is an increased uterine peristalsis in patients with intramural fibroids, the chances of myomectomy may improve the pregnancy rate. The only problem is that measuring uterine peristalsis using cine MRI is difficult and is expensive. It's not something that we can do routinely. So that is our problem. So the next question is, beside myomectomy, can we do something else to reduce first the size of the fibroid, which has already been touched on by our second speaker? And another thing is whether we can reduce uterine motility, the uterine peristalsis, so that the patient can achieve a pregnancy. Now, these are the few that I'm going to touch on. I think the second speaker has spoken much more, antagonists and all that, which I didn't touch. So here I will just touch on uripristal acetate, GnRH agonist, etosiban, uterine artery embolization, and then finally the topic of high intensity focused ultrasound. So let's look at uripristal acetate. We know that this is a selective progesterone receptor modulator. It has advantage over myomectomy because the patient can conceive immediately after treatment. And as shown earlier by the speakers, there are many studies that have shown that you probably can shrink the fibroid and can achieve pregnancy. But most of the studies that I've seen are mostly type 2 and type 3 fibroids. It has never been studied on type 4 fibroids. So if a patient has got a small 2 or 3 centimeter fibroid that is not touching the endometrial cavity, would you put the patient on ulipristal acetate? In my country, ulipristal acetate has been banned. I think it's still available in India, but I am not used because of the liver failure problem. So I think you can try this to shrink the fibroid and then patient to get pregnant on their own or to do IVF. I think this is one option. So next is gonadotropin releasing hormone agonist, GnRH agonist. We know that GnRH agonist binds with GnRH receptors, desensitizing and ultimately reducing E2 and P4, causing reduction in fibroid growth. Now, GnRH also acts on the GnRH receptor expressed by the fibroids to reduce cellular proliferation. During this process, water diffuses out of the fibroid cells, causing shrinkage of the fibroid. Because there's a lack of studies to determine the effect of GnRH on fertility, we postulate that significant reduction of fibroid volume by GnRH may reduce the impact of cavity encroaching fibroid and subsequently improve implantation. Now, again, here, we don't have any study that shows that non-cavity distorting fibroid using GnRH analog to make it smaller will achieve pregnancy. So this is another area of research that people can look at. They have done on bigger fibroids, and it has been shown by previous speakers. But what about the smaller fibroids? Does shrinking a 2 to 3 centimeter intramural fibroid by GnRH actually increase pregnancy rates? We are not sure about that. Now let's look at etosiban. Now we know what etosiban is actually an oxytocin and vasopressin receptor antagonist. As an oxytocin receptor antagonist, etosiban competes with oxytocin at the oxytocin receptor in the endometrial cells to decrease endometrial contraction and prevent embryo expulsion during the implantation phase. By reducing oxytocin effect, it inhibits oxytocin-induced prostaglandin production and increases endometrial blood supply. So as a vasopressin antagonist, etosiban relaxes the uterine arteries and decreases systolic blood pressures to improve blood perfusion to the endometrium and myometrium. So this looks like an interesting drug that we could use. The antagonistic effect of oxytocin and vasopressin receptors also improve uterine receptivities and embryo implantation. So, but all studies that have been done on etosiban are on repeated implantation failures. There's no study that have looked at using etosiban for patients with small intramural fibroids that are not getting pregnant. But this is another area where people can look at to see whether this can be used in patients with small fibroids and whether we can achieve better pregnancy rates. Now, next is uterine artery embolization. Now, if you have a fibroid, you can, of course, use UAE. UAE is believed to affect embryonic implantation and difficulty in maintaining gestation and leads to increased miscarriage. The risk of amenorrhea and ovarian failure with UAE in young women is low. However, there is a worry of poor oocyte quality, poor response to ovarian stimulation patients who are undergoing UAE. Several cases of intrauterine adhesions, endometrial atrophy, and fistula between uterine cavity and an embolized myoma post-UAE have been described in the literature. In one study, more than 1/3 of the patients are found to have intracavity tissue necrosis 3 to 9 months after UAE. So American College of Obstetrics and Gynecology, the Society of Interventional Radiologists, and RCOG have placed UAE as a relative contraindication for women desiring future fertility. But I have actually spoken to some good interventional radiologists, and very good interventional radiologists say that it doesn't affect the ovarian function if you do it carefully and you spare the blood supply to the ovary. You can actually shrink small fibroids. But as a gynecologist, with a patient in front of you who has got a 2 or 3 centimeter fibroid, would you send them for uterine embolization to shrink the fibroids? I'm sure most of you will not. So I think this is also out of the question for a small fibroid. So let's look at high intensity focused ultrasound surgery. Now, HIFU is an organ sparing, non-invasive thermal ablative procedure. It uses an extracorporeal transducer to focus big intensity ultrasonic beams to the targeted myoma to thermally ablate the tumors without introducing needles or probes into the tumor. Now, there are two types of eye HIFU, MRI HIFU and ultrasound-based HIFU. There is minimal damage to the surrounding normal myometrium without obvious damage to the elastic and collagen fibers in the normal uterine muscle, resulting in less scar tissue formation and less risk of collagen fiber hyperplasia. Theoretically, this would reduce pregnancy risk in women who are undergoing HIFU treatment for uterine fibroids as compared to myomectomy. And we know that when we do myomectomy, they're cutting into the uterus to take out that small fibroids. All of us will be reluctant to do a myomectomy for a 3-centimeter fibroids. But if you want to do HIFU, there is no cut on the uterine cavity. So it looks like this may be one of the choices. So clinical studies have confirmed that HIFU avoids ovarian function. This has been shown by Dr. Aili, impairment and adverse reaction, thus preserve the ability to conceive. Studies have shown the pregnancy rate post-HIFU was 95.4%, which is slightly higher than post-myomectomy, which is 64 to 88.6%. Spontaneous abortion rate post-HIFU is 14.9, similar to post-myomectomy, and the rate is still significantly lower than pregnancy in untreated fibroids. So this looks like a very good option for this kind of patients who have got small fibroids. Maybe we could think of using high-intensity focused ultrasound surgery to shrink these fibroids. And I must say that I have just started providing this service in my hospital. We are now 4-month-old. I've done my 70th case yesterday. And in fact, the case I did yesterday was an interesting case. She came all the way from another state of Sarawak, which is Borneo. She is a 38-year-old lady who has been trying to get pregnant for the last 3 years. And she had done 3 IUIs and now contemplating doing IVF. Now, she had one 4.5 centimeter intramural fibroid, just about touching the junctional zone, another 1 centimeter fibroid in the center of the uterus, and another one small subserous fibroid. So she heard about HIFU and she came to me and said that, okay, I want to do HIFU. So I told them all the good things and bad things about HIFU and also myomectomy. And I gave them actually my paper. Go and read this paper. I am also not sure whether I should be doing HIFU for you. You have not even tried IVF. If you have failed IVF 2 or 3 times, then I do HIFU for you. It'll be good. But I am not sure whether if I do HIFU and shrink your fibroid, you can get pregnant on your own or even by IVF. So they thought about it and then ultimately they said, no, doctor, I'm going to go ahead and do it. It's the first case that I'm doing a small fibroid, ablating a small fibroid to help the patient to get pregnant. So this is what I am interested in. So in summary, there is enough evidence to show that non-cavity intramural fibroid affects fertility. Type 3 fibroids have a higher risk of poor pregnancy outcome compared to type 4 fibroids. They may cause, there are many possible causes why intramural fibroid affect fertility, but the only measurable cause appears to be increased uterine peristalsis. Now, I was talking about uterine peristalsis a lot because we don't have anything else to measure to tell us that intramural fibroid causes causing infertility. Uterine peristalsis seems to be the only one. But the problem is that unfortunately, all patients with intramural fibroid do not have increased uterine peristalsis. Not all. Some of them have, some of them don't. And we cannot have a good method, inexpensive method of measuring uterine peristalsis. Cine MRI seems to be an accurate method, but it is expensive. We can do by transvaginal ultrasound, but it's cheaper, but the modality, but it's still very user dependent. I constantly look at uterine peristalsis when I look for infertility patients. Some of them have, some of them don't, and it is not a very good science yet. A better method needs to be devised to measure uterine peristalsis early, easily, and effectively. Now, with vitrification, pregnancy after frozen embryo transfer is improving. I think many of us who are doing IVF now are almost going into 100% frozen embryo transfers because pregnancy rate are so much better after frozen embryo transfer than fresh embryo transfer. So myomectomy should not be the first line of treatment with small intramural fibroids, is my suggestion. In patients with many frozen embryos, the strategy could be to consider surgical or non-surgical intervention only in patients who have failed embryo transfer. So we are doing that all the time. We have got small fibroids and we do the embryo transfers. And if it fails, then we can consider other options. And myomectomy appeared to be a big procedure to perform in these patients with small intramural fibroids. And I feel terrible to go and do a laparoscopic surgery just to look for that small fibroid, which is very difficult to find. Maybe you have to do intraoperative ultrasound to locate that small fibroid and take it out. And it is a big surgery for a small fibroid. Of all the non-surgical methods that I've described above, HIFU appears to be the most attractive option to shrink this small intramural fibroid because it is non-invasive technique and with very few side effects. So this need to be explored in clinical studies, and this is my area of research, and I'm hoping that I will be able to publish some data on this area. Thank you very much. Back to you, Dr. Gopinath.
Thank you, Selva. Thank you for nicely illustrating what are all the points which we have covered and which we have missed it, and with all your inputs and then your management with your recent tool in your hand. It is really interesting to listen to. As we have been, the session was going on, lot of questions have come out in the chat, and then everybody was just getting their answers, I think. So I'm very, very happy that it has been really provoked a lot of interest, and it is really an enigma and really a difficult situation, especially as I was just mentioning it, when you come across an adenomyosis in an infertility patient, that is a time you feel like just taking a vacation and going, asking somebody else to take care, you know. So that kind of a frustration you feel when you see them. But we have so much of our options now available from what we gather from all our speakers put together. This is something like a cafeteria approach where one has to choose what the patient needs and what you have and what is your expertise and what is be a least invasive, and all that has to be taken into account while providing your service to that needy patient. I think I have to thank HIFU, especially Rosie and Anthony, for taking so much of efforts to arrange this program. And I have to thank the lovely speakers, Dr. KUNDHAVI, Dr. KURIAN, Dr. Aili, and dear Selva for enlightening the session. And it has really been an amazing evening on a Sunday with all of you.